Hello. Thank you for joining us today for this briefing entitled Obesity in America, Exploring Anti-Obesity Medications and Addressing Policy Challenges. My name is Mila Becker, and I am the Chief Policy Officer at the Endocrine Society. I will be serving as moderator. This briefing has been organized by the Endocrine Society, the world's oldest, largest, and most active organization dedicated to the understanding of hormone systems and the clinical care of patients with endocrine diseases and disorders. The Endocrine Society's membership includes over 18,000 clinicians and researchers worldwide, many of whom are experts in obesity, who are making significant contributions to the advancement of knowledge in obesity research, prevention, and treatment. Before I introduce our panelists for today's briefing, I want to share some important information to help frame our discussion and also to give you some logistics so our conversation will go well. First of all, obesity is an extremely common in the United States. According to the Centers for Disease Control, it affects 42.4% of adults and nearly 20% of children. People with obesity are at an increased risk for other serious diseases and health conditions, including cancer, diabetes, and heart disease, major causes of death and expense in this country. The obesity epidemic has also impacted our nation's military and national security. Only 2 out of every 5 young adults is weight eligible and adequately active to serve in our military. It is also estimated that the government spends about $150 billion in obesity-related healthcare costs per year. In the past 20 years, there have been major medical advances in pharmacologic treatment of obesity generated by research at the National Institutes of Health, and the FDA has approved several new anti-obesity medications, otherwise known as AOMs. These medications treat obesity and help individuals who have health problems related to obesity, including diabetes and coronary heart disease. A licensed healthcare provider, such as an endocrinologist, can prescribe AOMs to individuals with obesity. Research shows that taking these medications will result in significant and sustained weight loss and overall improved health. One study, published in the New England Journal of Medicine, reported a 20% weight reduction among people using these medications. Anti-obesity medications can be expensive, however, and fall outside of the scope of coverage provided by many private insurance plans. To be clear, the Medicare statute specifically does not allow for coverage of weight loss drugs. Consequently, Medicare doesn't cover these medications for weight loss, which creates a barrier for not only Medicare beneficiaries, but also those in private insurance, because Medicare often sets the standard on what is covered. Congressional action is required to allow coverage of these medications for obesity. It is not a matter of CMS changing its policy. Today, we will hear from 2 experts in the field of obesity medicine. Our speakers will review the latest advances that have emerged in obesity treatment, including the FDA approval of several AOMs. They will talk about how these medications work and dispel the common misconceptions associated with these medications. Finally, they will discuss the barriers that prevent patients from accessing AOMs and potential legislative actions that Congress can take to improve access. Now I'd like to introduce our 2 panelists for today. First, Jonathan Purnell is a professor of medicine at Oregon Health and Science University in Portland, Oregon, with board certification in both endocrinology and obesity medicine. Dr. Purnell has joint appointments in the OHSU Knight Cardiovascular Institute and Division of Endocrinology. He is the director of the Center for Preventive Cardiology, where patients receive integrated management of obesity, diabetes, and hyperlipidemia with the goal to improve cardiovascular health. His NIH-funded research areas of interest include understanding the causes and consequences of obesity, metabolic syndrome, and diabetes in humans. He is editor of the obesity subsection for the online textbook endotext.org and is a member of the Endocrine Society. Dr. Pereira is director of the Office of Health Equity and chief of endocrinology at Denver Health, an associate professor of medicine at the University of Colorado, Division of Endocrinology, Metabolism, and Diabetes. Her primary focus is addressing health disparities, particularly those related to obesity and diabetes. She has been a member of the Endocrine Society since 2001 and currently serves as a member of the Board of Directors, on the Committee on Diversity, Equity, and Inclusion, and as director of the Excellence in Clinical Endocrinology Leadership Program. We have reserved time at the end of the briefing for a Q&A section. We encourage you to submit your questions through the Q&A function at the bottom of the screen throughout the presentations, and I will select questions for Q&A after we've completed our discussion. Please indicate your name and your congressional office or organization in addition to your question. Please note this session is being recorded. All attendees have been put on mute to control sound quality of our speakers, and the chat function has been disabled. I will now turn it over to Dr. Purnell for his presentation. Dr. Purnell, please turn on your camera and unmute yourself and take it away. Thank you.
Thank you, Mila. Pleasure to be here today and looking forward to getting feedback and questions from everybody. I am going to try to take you through about 20 years of discovery on the science behind weight regulation and obesity and how that has led to new therapeutics for us. Ellie, if you could go to the next slide, please. These are my disclosures. I am an advisor for both Novo Nordisk, which makes at least one of the current medications we'll be talking about, and Rocio Pharmaceuticals. Ellie, next. The title of my talk is Treating Obesity as a Chronic Disease, a Call to Therapeutic Arms. And one of the key aspects of this discussion today is understanding obesity as a chronic disease. And what do I mean by that? We're used to treating chronic diseases in our clinics in primary care and specialty medicine. And typically they might be things like diabetes and hypertension. Now, a hallmark characteristic of all chronic diseases is that they start from a very fundamental or basic physiology that usually regulates some vital life force. Like for diabetes, it stems from just the regulation of glucose by insulin and glucagon. For hypertension, we have a number of different interactions between organs to maintain our blood pressure, depending on when we, starting from when we just stand up and get up from the bed in the morning to making sure that we can go hike in the Colorado Rockies without getting dehydrated. But these fundamental systems go off and the physiology becomes a pathophysiology. So normal glucose regulation leads to high glucose levels. Normal blood pressure regulation leads to higher blood pressures and a higher set point. And then eventually, as a result of this pathophysiology, something bad happens in terms of our health. That could be retinopathy or eye disease or kidney disease or nerve damage or heart attacks with diabetes and similar cardiovascular issues with chronic high blood pressure and chronic kidney disease. But what about obesity? Does obesity fall into these categories? And that's what I'd like to lead you through next. Next, Ellie. So prior to 1994, our understanding of obesity went through a pivot point. Prior to that, basically, body weight regulation was thought to be a character flaw. Words like gluttony and slothfulness are thrown around quite a bit. In Dante's Inferno, it's referred to as one of the cardinal sins. But in 1994, with the discovery of leptin, a hormone made by adipocytes, which I'll talk about in a minute, this really changed our understanding of what determines our body weight. And basically, since then, the narrative, the discussion has been around weight regulation and physiology and pathophysiology. Next. So what governs our weight is a interaction between our brain, which includes the hypothalamus and the brainstem, our stomach and our intestine or GI system, and our adipose tissue. And the way this works, next Ellie, is that as we eat a meal, the food passes from the esophagus to the stomach to the intestine on there under the right. And this elicits secretion of a pattern of hormones. And these hormones travel through the bloodstream to the brain. And some of these hormones result in a sensation of fullness. We call them satiety factors. They're things that oftentimes we've heard about, like even insulin can function as a satiety factor. But the most common, the more prominent ones now are hormones like GLP-1, glucagon-like protein 1, and PYY. But they, as I mentioned before, convey a sensation of fullness to the brain as we're eating our meal that increases. And so our brain knows when those hormones are there that we're eating a meal. And in fact, the levels of the hormones in the blood actually convey to the brain how many calories we're eating in that meal. And this is actually how our brain knows how much we're eating, not because we looked at the food on our plate and said, oh, I'm going to eat this amount today. And then when that digestion process wraps up, the stomach is actually able, about an hour and a half later, to make another hormone called ghrelin that conveys to a brain, a hormone that conveys to the brain a sensation of hunger. So these feelings we have around the meal, feeling hungry before we eat, feeling full as we're eating, are actually conveyed by biological signals to our brain. And the very same neurons in the brain that receive those signals also receive another signal from a hormonal signal from the fat tissue in the form of leptin. And leptin basically tells the brain how much we weigh. Levels of it go up in the blood as we gain weight. More importantly, as we lose weight, fat cells shrink, they make less leptin. So the brain knows when we're losing weight too. And this part of the brain integrates these two sets of signals continuously through the day, moment to moment, meal to meal, day to day, to answer two questions. One, do we weigh what our brain thinks we should weigh? And that's the leptin signal coming in. And the other is, are we eating sufficient calories, or have we gone a while without eating calories? Are we getting enough calories to maintain that weight? And the point of this part of the brain, or this part of the brain, is what we call the set point of the brain. The job of the set point is to keep our weight within 5 pounds up or down. Usually you can express it as percent too, but usually it translates into about 5 pounds on a day-to-day, week-to-week basis of what our brain thinks we should weigh. So if our brain senses that we're losing weight because the leptin levels are dropping, or we're not getting enough calories because the gut hormone levels are dropping, or both are happening at the same time, our brain sets in motion adaptation systems to limit that weight loss and bring us back. And we all operate with a set point, every one of us who is on this call right now. Next, Ellie. So the set point, though, for 70% of our population will rise, and it'll operate somewhere above what we consider a healthy weight. And we think the primary reason for this is development of insulin or leptin resistance, analogous to insulin resistance that happens with type 2 diabetes. So if those neurons in that part of the brain are become leptin resistant, and this is a bit of an oversimplification, then those neurons need a greater amount of leptin signal to restore a balance. Now, in order to get more leptin, we have to put on weight. So we go through a period of weight gain. And unfortunately, the direction of this change, going from healthy to overweight or overweight to obesity, is one way. The set point rises, but it doesn't come down on its own. And unfortunately, that part of the brain doesn't know that that weight might be unhealthy or might be causing trouble with sleep apnea or diabetes or joint issues or fatty liver or any of a number of other issues. For all that the brain knows is that weight is normal. So it will defend 200 pounds just like it did 120 pounds. Next. What's also not greatly appreciated is the peak age for obesity is around 60 years old. So you can be normal weight in childhood, 20s, 30s, 40s, and 50s, still put on weight and develop obesity through this system. So you're not guaranteed to not develop weight. In fact, the majority of people will develop their obesity in adulthood. Next slide. And there are over 200 known complications of developing unwanted weight gain, especially around the middle, the central distribution. They're listed here in the most prominent ones, the ones that soak up the most amount of healthcare dollars right now. And as you can see, primarily cardiovascular disease, which is still the leading cause of death. But not only that, but also at least 10, if not more, cancers have been associated with obesity. And so the two leading causes of death are basically either downstream or influenced heavily by obesity. Next slide. So obesity, yes, does check those boxes. There's a normal physiology that governs all of our weight. We call the set point. There's a pathophysiology of leptin resistance that leads to a rise in that set point. And unfortunately, the brain defends that new weight. So patients will be doing all the right stuff in terms of lifestyle, and their brain will just not allow them to go down. And then the consequences for many people who have, if not the majority, who develop obesity are severe. Type 2 diabetes, dyslipidemia, and as I mentioned, over 200 other complications. Next slide. So what can we do about it? Any chronic disease, whether we're talking about diabetes, hypertension, hyperlipidemia, or obesity, foundationally, we still recommend people start with lifestyle. But as we can get into in the question and answer part later, lifestyle has a very limited role to play once you have already developed obesity. The studies, the best ones that are out there right now, the Diabetes Prevention Program, demonstrates about a 4% total body weight loss after 4 years of adhering to the most intensive lifestyle available we have on the commercial basis. So if you start off at 200 pounds, that's an 8-pound weight loss over 4 years, despite busting your butt to do all the right stuff. So if you have someone with obesity, that top graph there shows with the yellow arrow, you can get from maybe the top end of the range of your weight down to the lower range of your body weight set point, and that's about what lifestyle accomplishes. What lifestyle by itself and the vast majority of patients will not accomplish is taking someone from an obese status to a normal weight or healthy weight status. Next. So we have medications based on our understanding of physiology and the primary checkpoints involved with weight regulation. A number of medications have been either discovered or developed that treat body weight regulation and obesity. Next slide. This is just a simple graphic showing the currently 5 approved FDA medications that are available. These are considered by the FDA to be safe and effective for long-term use. All these medicines, once they're started, if they're effective, will continue the rest of the patient's life unless they have side effects for women if they get pregnant or if something better comes along. The last one down there, tirzepatide, currently known as Mounjaro, in the clinics for treatment of diabetes, is currently under review by the FDA for approval for weight management. The semaglutide 2.4 is the one that people commonly know of as Wegovy at this point. That's a 15% weight loss. Tirzepatide, or the Mounjaro hormone, results in a 20% weight loss. Next slide. So for those of you who want to geek out on the neurophysiology, this is a schematic that shows the sites in the brain where we currently understand these medicines are working. And the way that that manifests in the patient, if those medicines bind to the neurons in the pathways of the brain that got them to their overweight or obese status, then what they do is they electrically amplify the signals coming in that tell the brain that's full, so it takes fewer calories to feel satisfied, and they dampen down the hunger signal coming in, that ghrelin signal from before. So basically, we advise patients to eat mindfully follow those internal cues, and the medicines will do the rest after that. Next slide. Currently, especially with the GLP-1 receptor agonists that you hear about commonly in the news right now, those are things like Wegovy, and then the newer one, Mounjaro. With those medications, you're talking 15 to 20% long-term sustained weight loss. And the data that's just coming out in the last few years shows that if you have prediabetes, there's a 90% reversion to normal glucose levels. And if you have diabetes, prediabetes, none of those patients go on to develop diabetes. You have improvements in cardiovascular risk factors like lipid levels, blood pressure levels as well. And at least published by the Novo company website, they have outcomes from a trial of patients at risk for heart disease showing a 20% reduction in heart attacks, which is about on par with what you get with taking a statin at this point. Next slide, please. Now, I'm not a health economist, and I know we'll have some probably opportunities to talk in the question and answer later, but I just want to give you an idea about what this means in terms of cost savings. So this is an analysis of what a per case cost for someone with prediabetes, diabetes that's undiagnosed, gestational diabetes, or actually progressing from prediabetes to full-blown diabetes costs. So if you have prediabetes, that's $500 per case on average per year. If you have diabetes, you shoot up to $13,000 per year. And all those costs, in addition to the complications of diabetes, then contribute to what's estimated to be around $327 billion in direct and indirect costs for our healthcare system. So just imagine if you had a medication that took someone with prediabetes and converted them into normal glucose and prevented any of them from going to full-on diabetes, the cost significance would be substantial. The cost savings would be substantial just for diabetes alone. And again, we can talk about other chronic conditions like fatty liver, heart failure, and other things that have been demonstrated to have positive outcomes from the weight loss. Next slide. So these guidelines that have been out for managing diabetes or for managing obesity have been around since 2013. And they have been accepted by both the primary care societies and the specialty societies. Next slide. But if you look at the number of physicians who are offering these medications to their patients, it's only 1% of eligible patients are being offered anti-obesity medications, which we call these class of drugs, compared to 80 to 90% of patients being offered a new drug for diabetes, shown there on the right. Next slide. So why is that? We'll start at the bottom. A lot of physicians still don't still don't have an understanding of weight regulation and physiology because we don't teach it very well in the medical schools right now, although this knowledge has been around for 20 years. We're working on that. There's a misunderstanding that these drugs carry an extra burden of poor outcomes, safety outcomes from previous drugs. And then there's a misperception that these medicines are only for short term, that this is not a chronic condition. This is something that they can just treat for a few months and then stop, and they'll be able to do it on their own. All those things we're working very hard to change in terms of our educational seminars and getting the word out there for physician colleagues. But the one thing we can change is that insurance, especially Medicare, does not cover these medications. And by default, majority of states, Medicaid doesn't either. So we're being held up by that. Next slide. So right now, obesity, as we heard about before, affects 40% of the US population, especially those who are older with a peak age of 65 in the Medicare population. Also those most vulnerable, we'll hear about in the next talk, lower socioeconomic status and communities of color. So, and we now consider, based on our understanding of physiology and pathophysiology, for obesity to be a disease. So we need to start treating it like one. And of the three foundational approaches for any chronic disease, lifestyle, anti-obesity medications, and bariatric surgery, Unlike diabetes, unlike hypertension, unlike hyperlipidemia, we are now have no available covered medication, anti-obesity medications in the Medicare space and many states, the Medicaid space, and by default, many of the private insurers because they followed Medicare's example. Next. So thank you. I think we're going to take questions later.
Hi, everyone. Thank you again for joining us. I am Pereira, and I'm going to follow up Dr. Purnell's lecture talking about disparities in obesity and disparities in access to anti-obesity medications. Next slide, please. I have no disclosures. Next slide. So I will start talking about the racial and ethnic disparities in diabetes, and then talk about the disparities we see in the access to diabetes medications. And finally, we'll focus on the consequences of obesity and obesity treatment disparities. Next slide, please. I want to start before I talk specifically about disparities in obesity. I want to remind us that disparities in healthcare, are extremely costly to our system. So this is data from a recent study that was published in the Journal for American Medical Association, and it shows the economic burden of health disparities related to racial, ethnic differences, and also disparities related to educational level. So on the top panel, we see the racial ethnic disparities, and they account for more than $450 billion of our GDP, our economy. You can see that this excess cost is due to premature deaths, lost labor productivity, and excess medical care costs. And similarly, disparities in educational level for our society are associated with huge costs in terms of health, and those primarily affect people who have less than high school education. For the racial ethnic disparities, those affect mostly our Black, African-American community and our Hispanic Latino communities. And we know also that there is a great deal of overlap with many families in the Black, African-American community and Hispanic communities also facing financial burdens. Next slide, please. This slide shows you the percentage of adults aged 20 and over who have obesity across the different race groups. So that first set of columns is the total percentage, and then next is divided by men and women. And you can see from this slide that more than 1 in 2 Black women in the US have obesity. And this is much higher than the percentage of women who are white or Hispanic who have obesity. And you can see disparities across the 3 groups of columns here. Next slide, please. This slide shows you the percentage of individuals who have severe obesity. On the top line shows you the total, then the difference by men and between men and women, and by age, and then by race, ethnicity. And here we're looking at severe obesity. So this is the highest level of obesity, which we know is almost always associated with complications. And from here, we can see that severe obesity is more likely to affect women, adults in their 40s and 50s, and in particular, Black adults. Next slide, please. This map shows you the prevalence of obesity, and this is self-reported obesity, so it's likely an underestimate. across the United States in the different states. And this is data from 2022. So this is a post-pandemic. And you can see from this map that most of the regions, most of the states are either orange or red, showing that the percent of individuals with obesity is 30 or more percent. And in fact, our darkest areas there, the states with the darkest red, have in their population 40 to 50% obesity rates. Next slide, please. These set of maps show you the different prevalences of obesity across the different race ethnicity groups. And here you can see that compared to non-Hispanic white adults, Hispanic adults, American Indian Native adults, and Black adults are more likely to be affected by obesity. And you can see from the Hispanic adult chart that this is, most of the states now show a 30% or more prevalence of obesity, and there are states where that is higher. In the American Indian Alaskan Native adult map, you now see two new colors, one showing the percentage of 45 and above, and the other 50 and above. So 1 in 5, I'm sorry, 1 in 2 American Indian or Alaskan Native adults in some states have obesity. And similarly, the rates are very high for Black adults. Next slide, please. We also know that the prevalence of obesity among children and youth is very high for minority populations. Here we're looking at a map showing trends in obesity rates in children and youth 2 to 19 years of age, starting from 1988 and going through 2018. And the top two lines are showing us the rates of obesity for youth who are either Mexican American or Black. And we can see that those two lines have been continuing to increase. The percentage of children and youth who are white with obesity has also increased, but not quite at the same rate. Next slide, please. And we heard from Dr. Purnell about the consequences of obesity. Obesity has a number of physical consequences, including most commonly type 2 diabetes, also hypertension, heart disease, cancer, arthritis, and these are very likely to lead to disability. Obesity also has consequences in terms of mental health. Individuals who have obesity have more risk for having low self-esteem, for having mood disorders, for having low quality of life. And individuals who have obesity also suffer in their social health. They often face stigma, they can face discrimination and ridicule, rejection, and humiliation. Next slide, please. And we know that the cost of obesity is very high, nearly $173 billion in 2019. And adults with obesity spend $1,800 more for medical care. Next slide, please. So we would ask, why don't we all just eat healthy and exercise? And Dr. Purnell very nicely showed us the different pathways and steps that are involved in regulating diet and exercise, and lead to obesity. I want to also talk to you about the behaviors and what regulates our behaviors of eating and physical activity. And in part, it is these pathways that connect our brain to our gut and our hunger sensation. But in part, it is also our environment. So, and our social environment and our physical environment. These eating and physical activity behaviors are learned. Next slide, please. And they're affected by the social cues that we have around us. So, for instance, you are more likely to eat a healthy diet if you live in a place where you are surrounded by healthy foods. Your closest source of food is a supermarket that has fresh fruits and vegetables. Then if your closest source of food is a place where you can buy fast food that has very high calories. You're also likely to eat better if you have a way to get to your supermarket and to bring home your fresh produce than if you don't. And you're more likely to exercise if you live in a place where there are a lot of green spaces and there is fresh air and no pollution. Next slide, please. And this map shows us the percentage of families where there is no car and no supermarket within a mile. And you can see that the darker areas are the places where there's more than 10% of households that have no car and no supermarket within a mile. And you can see that those areas tend to be in areas, if you remember the map, in areas where we see higher prevalence of obesity. And it's also quite striking that these disparities are geographic. So there are states that are much more affected by this issue of not having access to healthy foods. Next slide, please. So when thinking about preventing obesity, there are a number of different steps that we can take in terms of change in policy. And change in policy needs to focus on increasing healthy options. So increasing the availability of healthy foods, the availability of healthy foods in schools, the built environment. We need to also think about the barriers that get in the way of people's healthy behavior. So regulate the promotion of unhealthy products, which are targeted more towards minority members. The higher cost of healthy foods, the threats to personal safety that keep people from going out and exercising. We need to build community capacity and work with entrepreneurs, businesses, policymakers, everybody, really to decrease the disparities that we see and prevent obesity. And we need to improve the social and economic resources that our minority communities have. Next slide, please. Mila mentioned at the beginning the fact that Medicare cannot just start covering the medications for the treatment of obesity because this is currently not allowed by law. But this is a very important population, the Medicare beneficiaries. And if we look at that population in terms of obesity, we see that the percentage of obesity in the Medicare beneficiary population has increased significantly since 2010. It's gone from 6% to more than 21% as of 2019. And we can see again the disparities in obesity just in this population of Medicare beneficiaries. Being able to cover the latest medications, the very effective medications we now have for obesity treatment would allow us to prevent diabetes and arthritis and heart disease and cancer in these individuals and others. Next slide, please. So in summary, racial and ethnic minority populations have higher rates of obesity and its complications, importantly, diabetes and other very costly complications. They are also the least likely to have access to obesity prevention services or to treatment services. And these disparities in obesity are very costly in terms of the diabetes and arthritis and heart disease that result. And policy efforts to increase the access of both obesity prevention and treatment services for our low-income minority populations is desperately needed. And that is the end of my talk. I will turn it back over to our moderators. And I believe we're going to have some questions.
Yes, we are. Thank you very much to both of you for your presentations, for setting the stage, and for sharing so much information. Perhaps something we should have done at the outset, though, and Dr. Purnell, I'm going to turn to you. When we talk about obesity as a disease, we're not talking about people who need to lose 20 pounds. Can you give us a little bit more of a definition of what it is to be obese? What classifies as having that disease?
Great question. Historically, it's been defined by your weight, and that has been on the norms developed in Northern European populations on body mass index. But we now recognize as a definition that obesity represents an excess collection of fat in three ways, actually. Total amount of weight, regional weight around typically what we talk about without moving around the middle or the internal organ area. And then you can also accumulate fat in form of lipids within organs like the liver or the muscle. And what defines this accumulation as being a disease falls on two key aspects. One is that you could, as a result of this accumulation, have manifestations of an adverse health outcome. And that actually comes from the World Health Organization. So you could have increased fat in liver, you could get fatty liver, you could have risk for, you could have diabetes, you could have hypertension, you could have sleep apnea, you could have arthritis, you could have a lot of different things. But you actually don't need to manifest a specific disease or a complication of obesity in order for it to be classified as a disease. All you need is the increased risk. And an example of this comes from diabetes. If you're familiar with how to diagnose diabetes, we use it based on either blood sugar or an A1C, which is a marker of long-term glucose control. So typically you have to have an A1C above 6.5%. And that level is the level not that you have, once you cross 6.5%, that doesn't mean you have eye problems or nerve problems or kidney problems, but you have the risk for it. And the higher you go on the A1C, the greater your risk, or the sooner you will be to develop those complications. So an important point to me when you're talking about discussing about obesity as a disease is think about how we already manage other chronic conditions or talk about it within either the clinic or within our society. And so this is exactly how we do it with obesity now.
And I just want to add, in addition to the effects of obesity on our what we call metabolism, so the way our body's functioning inside, there's also consequences in terms of the mechanics of our body. So the ability of our knees and hips to support that extra weight. And so there is increased wear and tear on our joints and tissues, and this causes problems as well.
And I getting to the heart of the question, I think you don't have to have a defined BMI in order to meet that threshold for either what Dr. Pereira was talking about or what I'm talking about. It can be a measurement on a waist circumference. It could be so you could be actually what we consider normal weight in terms of a BMI, but still have obesity in the central form. So.
Okay. Thank you for that. I want to follow up on another point that both of you touched on in your presentations. And maybe Dr. Pereira, you can start us off. We often hear that fighting obesity is a matter of eating less and exercising more. It's just not that simple, according to your presentation. Can you discuss that and how these AOMs can help ensure that lifestyle changes will be effective?
Yes, absolutely. So yes, I mentioned that our eating and our exercise behaviors are not just dependent on our willpower. They are very much affected by the people around us, the environment we live in, the availability of healthy foods. And so what the medications do is they help to change the pathways, the connections going on internally that make us hungry, that make us crave things, that make it harder for us to eat healthier foods. And so that our environment, in terms of our diet anyway, our environment is not as influential. So it sort of tones those pressures down so that we are more able to choose what we're eating and eat a healthier diet. And Dr. Purnell can talk more about the internal pathways and the brain connections.
Yeah, the historically the eat less and exercise, or eating less and exercising more is what I term the thermodynamic model. Energy in, your body weight equals energy in and energy out. And so if you want to change your body weight, all you have to do is eat less and exercise more, both, and you can lose the weight. That is true. That has to happen in some measure, but our system actually is better described as a homeostatic model, one in which energy in and energy out is regulated. So, and in fact, the better term is probably allostatic, because as we start to, if our brain has a weight that it thinks of as normal, and that's what we call the set point, then once we start eating less and exercising more, those changes are sensed by our brain, and that evokes these counter-regulatory or adaptation responses in terms of energy expenditure, and then activates the appetite system so that you slow down on any weight that you're trying to do, and it comes back again. So for all the brain knows, again, let's take an example of a woman who's 5'2", weighs 200 pounds. If the brain thinks 200 pounds is normal, then when the brain senses there's a change in food intake or energy expenditure or both, then for all it knows, that person is getting up in the morning looking for food but not finding it. So the brain is trying to make sure that the body stays, capable of continuing that quest. And so what we need to do is be able to recognize that there's a biology in the background, and that people are doing their best that they can. They're not being dishonest with you when they say they're trying to do everything they can. They're not being dishonest with themselves. For the most part, what they're running into is their biology and their physiology, and that's where the medications work in concert with, in partnership with lifestyle. As Dr. Pereira said, oftentimes the availability of the foods that are around us do influence this system for sure. It's very important that when we are trying to manage with medications, understanding the physiology, that patients have access to, like she said, safe environments where they can be more active, healthier food options that allow maximal effectiveness of the medications, and for those who qualify, bariatric surgery as well. So it is not as simple. If it were as simple as saying eat less and exercise more, I certainly wouldn't be here. I don't think any of us would be having this discussion. It would be like telling someone with hypertension, oh, you just need to drink less water and you'll get dehydrated. And then by dehydrating yourself, like that quarter cup of water, you're going to lower your blood pressure. But then you're going to walk around tired, thirsty, dizzy when you stand up, And you're not going to get any better until you drink that water back again, your blood pressure's up again. And then you're stuck.
Well, thanks also for that little tidbit about dehydration and blood pressure. I don't think people were expecting that.
See?
Dr. Purnell, you talked about the economic burden of obesity, and this is also really at the heart of some of the policy debate that we're seeing. We know that obesity has a major impact on costs in this country. But when you look at some of the legislative proposals, particularly the Treat and Reduce Obesity Act, which would allow for coverage of these medications, they also come with a cost. Can you talk a little bit about if people have access to these drugs, will that help lower other healthcare costs?
And
So
Mila, I
thank-
missed, oh, sorry, go ahead.
Right.
I missed who you were addressing, so I thought I heard Dr. Purnell.
Both
Go
of you put
No,
that back.
Dr. Pereira, let you go ahead.
Okay. Yeah, I can start. So what I think what we have to take into account is the cost of the consequences of obesity in terms of wages lost, in terms of costs for diabetes in particular. Diabetes costs are incredibly high, because diabetes it leads to other things, as well as heart disease. And so when we're thinking about the cost of these obesity medications, it's really, if we don't treat obesity, we're just waiting for diabetes to happen. We're waiting for cancer to happen. We're waiting for osteoarthritis to happen. And those are much, much more expensive to the individuals that have these conditions, to our entire society. So really, it's just a matter of which is the least expensive, and the least expensive is treating obesity, so we're not ending up having to treat all these other conditions.
And I couldn't agree more. I think that is very well said. I mentioned I'm not a health economist, but if you look at all the different areas, the diseases that obesity touches, every specialty out there, rheumatology to orthopedics to surgery, is having to deal with the consequences of a growing obese population. And so, the example I gave was just one of if you could prevent people from getting diabetes, you got $14,000 per case savings. But then there's also the complications of diabetes that aren't factored into that. Going to see the ophthalmologist, getting your fitted for your boot because you've got drop foot, having kidney dialysis. Those are all prevented as well. And that's just diabetes. So there's just a recent study that came out about heart failure now, showing a big improvement in outcomes from that. You can almost eliminate fatty liver. You can get people, and then there's the disability and all those things. So the downstream effects are, going to be probably 5, 10, 15 years down the road, for sure. So there will be a delay in that, and the upstream costs will be generous, but that's not up to us as physicians. I don't think we can help guide policy on that, who gets it and when. But I do believe the numbers will bear that out. And another example of that is we have seen a reduction in obesity-related mortality in the last probably 20 years. Not because suddenly going from overweight to obesity is a healthier situation than it was before, back in the 90s, but because we've gotten better at treating the complications of obesity and preventing them from dying from their kidney failure and other things. So that improvement in mortality now you see with people with BMIs of 30 is because we're treating with our dollar costs have gone up so much to do that. And that's what we want to prevent down the road.
I will also add regarding costs that it's not that nobody can afford these medications, right? People can currently afford these medications, but not everyone can afford these medications. So the disparities that we see are real, and this disparity in access is going to increase the disparities we see in diabetes, and all these other diseases. And again, that is incredibly costly to us as well.
Yeah.
And right now, as we were pointing out, we were talking about before we got on, right now, federal Blue Cross Blue Shield, federal workers have access to these medications. And so the senators and representatives in Congress do, but the farmers, the rural farmers in Oregon, or the city workers in Portland don't, because who are on Medicare, at least.
Let me take one more question that we got from our audience, because I think it so perfectly sort of summarizes some of the policy challenges that both of you talked about in your presentations. And the question is, what are some of the greatest barriers that are making obesity medications less accessible to populations that need it? What legislative actions need to be done to help alleviate this? Dr. Pereira, maybe you can start.
I will start. You all need to change the law so that Medicare can cover these medications. Medicare cannot cover these medications right now, and that is the one change that needs to happen. If Medicare covers them, the private insurers will cover as well, and eventually Medicaid programs may cover. But really, that is the one barrier, is it is not covered by Medicare, and that makes it very costly for everyone.
Okay.
I agree. I have nothing to add.
Okay. Then before we conclude, I want to summarize some key takeaways from our briefing today. First of all, obesity is a disease, and it has significant costs to our country, including increased disease, substantial healthcare costs, significant health disparities, and effects on national security. There are medications now that are proven to be effective for the treatment of obesity. AOMs are currently not covered by Medicare, which would require the Congress to change the statute. Otherwise, we are dealing with a situation where federal money was invested in the NIH to research this. The FDA spent resources to approve these medications, yet people do not have access. Lifestyle interventions are also an important tool to treat obesity. We know that in combination with the use of these medications, the medications can be even more effective. And finally, more NIH research is always needed to find better treatments. The Endocrine Society encourages all of the participants to review our obesity resources on our website, including our obesity playbook. The playbook is a go-to guide for congressional staff, which includes background information, scientific information, policy options, information on what the administration and federal agencies are doing on this issue, and a list of Endocrine Society experts who have expertise that you can go to for consultants. We encourage all of the participants to review the information in the playbook. We will be sending a link following this briefing. And finally, we would like to acknowledge that funding for this briefing was provided through support from Novo Nordisk and Eli Lilly and Company. We thank them for their support. On behalf of the Endocrine Society, thank you for joining us today. We hope you found this discussion helpful and realize the urgency of this issue. Thank you very much.